next presentation is going to be focusing on mood disorders and very much looking at it from a family medicine sort of Ward 5 CHC district hospital point of view. And we're very much going to obviously look a little bit at DSM, DSM-5 and the EML. But within family medicine, we have a much more practical approach than necessarily doing the psychiatric route. So we're going to try and find an approach that combines both our EML perspectives with the DSM-5, and I'm going to particularly be looking at the DSM-5 perspective. So I want to first start off just with the basic neurophysiology, and usually we cover the sort of, the serotonin and the synapses and all of that, but I'm going to focus today on what is called affective neuroscience, which is a bit of an understanding on emotions and mood. And this also is helpful in terms of being able to explain to patients what is happening when they're experiencing something like anxiety or depression, for example. And those of you that have heard me talk about this, I use this neuroscience in a wide variety range of presentations. And I'm going to use an analogy to describe a little bit how our brains and emotions and behavior work. And I like to think of it that you have yourself, and then you have something that I'm going to call the double. It's somebody who looks exactly like you, and who talks exactly like you, and has got the same name as you, and is out there in the world. And sometimes this double steps forward and behaves in a way that might not actually be concurrent with who you are. We're going to explain a little bit, describe a little bit about what that is and why that exists. So we have these two parts of our brain. We've got the survival brain, which is the ancient part of the brain, and the sort of the limbic part of the brain, where the center for our survival system lays, right? And this part is very old in our evolution. It's been with us for millions of years. We share it with the animal kingdom. And this has got those basic instincts and drives that we'll talk about in a little bit more detail. And I'm going to use the analogy of imagining that this part of ourselves, including all our endocrinological system, all our hormones, is this beautiful, powerful, but rather stupid dragon. And then we have a prefrontal cortex, which is much newer in our evolution. This is what I'm going to call a master brain. And this part of us has got these new qualities that has come with the development of the prefrontal cortex, such as self-awareness, empathy, reflection, self-control. And you can imagine this is a dragon master that controls and is supposed to control and steer this beautiful dragon that we have, that is our physical body with all its hormones. So when our master brain and our survival brain are beautifully integrated, that I'm going to call our authentic self. This is who you are. When you think in terms of when you say I to yourself, when you introduce yourself, this is usually who you refer to, this whole person with all of these different aspects of yourselves. But there are scenarios where only the survival brain takes over and steps forward. And that is what I'm going to be called the double. And every day when you go through your life, there are times when you're there as your authentic selves, and then there are times when your double steps forward. So you can imagine that these two modes that you're in, either yourself, authentic self, or your double, these two modes are controlled by very physiological processes. So you have your limbic brain there. You can see on the double, that is your double. That is limbic brain led. That's how your double functions. Or you have your authentic self, your prefrontal cortex led, when that survival brain is not in charge. And the thing that makes a difference in which mode you're in has to do with anything that threatens you. So remember, we have this genetic part that likes to survive. And so anything that threatens us physically or emotionally or in our freedom of expression, being able to do what we want, triggers our adrenaline. And this is literally the switch that will toggle between which part of you is out there engaging with the world. So let's just look what it's like when our authentic selves are in charge, when we are actually we are calm, we relax, that not too much adrenaline in the system. And when you're in that setting, it's like you have a balcony view in terms of what's happening in your life and where you are at. And you have these amazing capabilities that's provided through our higher prefrontal cortex. So you have the ability to executive planning, you're able to reflect, you're able to be empathic, and you have self-control. You're able to inhibit the impulses coming from your lovely dragon. You can see things in context and with perspective. You've got a balcony view. And this is where this part of our brains is all about meaning and self-actualization. Who am I? What do I want from life? Where do I want to go with life? And when we are in this part of our brain, we're able to access the slow thinking circuits. You're actually able to access the parts of your cortex that has to do with maths abilities, for example, or language abilities. This is where we are rational and logic. And this is a much slower way of thinking. And this is where we are at our most intelligent. So this gives us the abilities to have these amazing qualities that we know in human. We're able to be compassionate and tolerant. We have a conscious. We're able to be humble and generous. This is where we're at our most creative and innovative. This is where you're flexible. And this is where you're generous in your assumptions about other people, which we live in a world of social media, but does not feel quite so generous. And this is where we can really be healing and loving in our approach to the world. So when we are within this part of ourselves, we have access to what I'm going to call 3 major positive emotions. They're very well described within neurophysiology. We also share them with the animal kingdom. But in this scenario, these positive emotions has also got this higher self of us present. And that one is care. They're also all hormonally mediated. So oxytocin is the major hormone involved with care. And whenever you get care for friends, for example, or whenever you care for an intimate partner, or whenever you care for a child, for example, you are within this care space. And I quite like to think of these, this is from Emily Nagoski, as emotional rooms that we can spend time in. And this is all of these positive rooms is a little bit where we experience a feeling of contentment or happiness. The second one, we also share this with the animal kingdom, is play. This is doing things for its own sake, for no other sake. And this is really where friendships are formed. This is all the stuff you do for fun, or your art, where you're going out, where you're watching movies. And then the third positive space, which is a space we're all sitting in right now, I hope, is the seek space. It's what animals have as just basic curiosity. But in human beings, this is the drive to learn, to explore, to find out new things, to solve problems. And these are all very positive spaces. And you can imagine if you're working down in Ward 5, you would want to be, if you want to be a happy doctor, you want to be in those spaces when you're working. And specifically for us as doctors, we're usually in the care and the seek spaces when we are seeing patients. If you are in those spaces, you will have amazing consultations. And I'm not going to talk about lust, which is the 4th favorable space. But what happens if we're only in survival mode? What steps forward when our survival mode gets triggered and that adrenaline comes in? And what happens is that your brain literally cuts off the blood supply to your higher prefrontal cortex, and you get what I call street view. It's like you're in those video games and you're just seeing what's right ahead of you. And you're very much focused on the present, and your brain is very much focused on survival. You become quite paranoid and vigilant when you're in that state because you're looking for all possible dangers. And this programming is very genetically determined. Our thinking now goes very fast and emotional. We make assumptions. We jump to conclusions. That book there, Thinking Fast and Slow, will tell you everything you need to know about bias. It's unstable and inconsistent thinking. You think this the one day. If you're emotional, you think something different the next day. And this is our powerful thinking. This is our go-to thinking. This is where we go to first when we're stressed, but it's not the cleverest part of ourselves. So if you were in a relationship or in a scenario where you did something where you really thought afterwards, why did I do that? Well, that was not the best way to handle that. That was your dragon or your double that stepped forward. So the dragon has got a dopamine reward system because it's about survival. So if you've ever had road rage and you have that indignant, righteous indignation, there's a certain satisfaction in actually getting angry. And we're very self-focused and proud and insecure in the system. We're not able to listen. We're not able to step into somebody else's shoes. And you have this very harsh emotive judgment we see so strongly on social media, where you will very quickly jump in with an opinion on things. And of course, you've seen this in A&E, whenever we see aggression and danger, that comes from that particular mode. So our double has got 5 major drives, and I'm not going to cover these in detail, but we need our food and resources. We need security. We need to feel safe. We need to have an intimate partner we can bond with. We need a troop who is our people, who belongs to us, and we need a certain amount of power in society. You can see in the world, if you look at the worldwide at the moment, still within politics, you can still see the rules of this world still very much lives within politics and in the wars that's happening in the world at the moment. So when the double steps forward, when you're in survival mode, there are 3 major negative emotions, also physiologically keyed, that gets triggered when you are in that space. The first one is the panic grief system. And these names are from Jack Panksepp, who wrote Affective Neuroscience, and he describes all the neurobiology of each one in detail. And you can imagine a small child when they lose their kid, you know, say you've got a small baby and the mom leaves the room and suddenly doesn't know where she is. And you will actually get this, well, not even that small, maybe 6 months, 8 months, they notice the mom's gone and they panic. They literally go into a feeling of distress and they start screaming. If the caregiver stays away and doesn't come back, that actually goes through a phase of grief and loneliness and abandonment, and eventually can actually end up feeling numb and apathetic. So this particular emotional space is actually different than fear and rage. It's a different space of feeling completely lost and disconnected. And this is the emotional space in which depression lives. Second emotion is fear. So that is one of our primary survival mechanisms. Unsafe, move away. That can include from little bits of worry to full terror. And any threat to safety, those 3 levels we talked about, can trigger fear. And of course, all of our anxiety disorders lives in this space if you get stuck within this fear space. And the third one is rage. And I love that definition. So when anything feels unsafe, there's a move to destroy. And it's the biological impulse to destroy an obstacle that's in the way. Think a little bit of road rage as well. And that's actually where people will have a motivation to break things. And you see all of the results of that in A&Es on the weekends, on what happens when rage takes over. And of course, aggression lives here. Emily Nagoski talks about these as tunnels because they're physiologically keyed. There are hormones that's making you experience these things. And therefore, you can't just snap out of it. You can't just go, okay, no, I'm not going to be angry, because your whole body is got all these endocrinology that's driving these particular emotions. So they're important emotions for survival, but the challenge is if you get stuck in them, or if the double is making decisions using these emotions, that's usually where things start going wrong. So the challenge with anxiety and fear and all of these emotions is that we do not like experiencing anxiety. It makes you feel it's very unpleasant. And so we have these mechanisms that deals with anxiety. So we have genetically got the fight, freeze, fawn, flight response to help us deal with threat. Now, these are quite clever in physical threats to safety, but they're not so clever in relationships. So if as a little child you ran away whenever you were frightened about something, as an adult, you can't run away every time you're frightened of having an argument with your partner or frightened of a patient in A&E. So the challenge is we have these little mechanisms we have built up that we use to try and reduce our anxiety. And generally what happens is it makes things worse. So whenever people are behaving badly, you can be sure that one of these mechanisms are in play, and Shajat calls them saboteurs. And I'm going to run through them very quickly. And what you'll see is when people are in depressed, anxiety, or rage states, these saboteurs come forward much more often because you're meeting this double. So there's fight, freeze, and flee mechanisms. There's lots of different ways you can classify it. Classically, you know, these as projections or defense mechanisms. But you need to see these as mechanisms that we all use to reduce our anxiety. And we all have our favorites. And they're quite powerful when they come up. So some people tend to go in fight mode when they're feeling stressed. That usually criticizing is our first thing. If you don't like something, if you're not sure about something, then you criticize it. We've got the government, so we always have somebody to criticize when we're feeling stressed. Or you overanalyze. All of us profs and teachers love doing this. So if you're somebody doctors who do like that analytical knowledge, then we like to give lectures, don't we? And give long, telling people lots of stuff they already know. If you all lectured your patients on stuff they definitely are already aware of, makes you feel better, doesn't help the patient. And of course, manipulating. I'm sure you all of those moms. I'm one of those moms, you know, those control freak moms with the Excel sheets. When you get stressed, then you start trying to organize and manipulate everybody else's lives. You can see all of those is things that makes you feel better in the moment, but actually they're terrible in relationships and they do not help you to meet what you need to meet. The freeze responses or fawning responses. So if you're somebody who's quite kind, who doesn't like conflict, you might go into pleasing mode. So you might try and, you know, if I'm nice, maybe he'll be nice, she'll be nice back. Some people find that they try and organize the space around them as a way to deal with anxiety. So that becoming over perfectionistic, struggling to hand something in or finish something, or being overly tidy or clean with the environment. And of course, our compulsive and obsessive compulsive behavior actually lies a little bit within this mechanism of dealing with anxiety. And then we all have that thing of 3 o'clock in the morning, worrying about stuff you can do absolutely nothing about, and wanting to try and bargain or think things through. And because you're in that negative part of your brain, you're not at your most intelligent, so you see all the worst case scenarios. And then the flee mechanisms, so you're not managing something, you're supposed to sort something out, so you just don't show up. So avoiding is a classic mechanism one can use to not deal with something you're supposed to deal with. Feeling very sorry for yourself, that's 3 o'clock also, and you're on call, wondering why did I study medicine? And then distracting. So we all have, I think we all do some of these at some times, but distracting, I think, is a universal favorite. So, and this is, of course, it's good to relax and do distracting stuff, but if the distracting things is coming in place of actually dealing with a problem, and it's actually becoming a way of managing your anxiety, then that becomes, of course, the base for addiction. So that goes right through from cigarettes, alcohol, opiates, your hard drugs, as well as your Netflix binging. If you're Netflix binging and not dealing with your studying, then you might be distracting yourself from your anxiety. So these mechanisms are useful to know and to notice, because quite often patients present in these modes. And you need to be able to identify that at this moment, the patient's not feeling safe. And what I'm meeting is I'm meeting this double, I'm meeting this dragon. And the real person is not actually present in those moments. Right. So just in terms of how daily consciousness works, therefore, the dragon is always active. Whenever we go through life, we have this survival brain. All of our sense impressions go through that area first. And we're constantly looking at the world going, is there any threats? Or is there any key drives? Is there food somewhere? Am I cold? Am I hot? And if things are safe, everything's fine, then the self can actually engage. Now you have access to your authentic self, and sometimes also you can just do those automatic behaviors. You know, your double can drive the car or brush your teeth or whatever, but you're conscious and you're able to be present fully, and you can really do innovative, creative stuff in this space. And this makes it possible for us to move into those positive emotional rooms that I was speaking about. But if there's a threat, if there's anything that triggers, that starts ringing that alarm of something that makes us feel unsafe, then the double automatically steps forward. The adrenaline just brings that part of your brain out, prefrontal cortex gets cut off. And the instinct is to just avoid the pain and follow that urge and use one of those saboteurs we talked about earlier. And what's important to understand is this is very subconscious in terms of how it drives behavior. And this can drag you into those negative emotional tunnels I've talked about. So your whole day is a little bit on how do you navigate your double versus yourself? Which emotional room do I find myself in? And how do I live a life where I live more within my positive emotional rooms and do not spend too much time stuck in these negative emotional tunnels? So we're now going to talk about, I'm first going to cover depression, and then I'm going to talk about anxiety. And we have to look at how the terminology works within the DSM-5. So mood is what they call the sustained emotion that colors the way we view life. So you literally get stuck in one of those negative tunnels we spoke about, which means also you don't have access to these higher functions. This is the DSM stats. So 20% of adult women and 10% of adult men at some time during their life are going to have a mood disorder, whether it is anxiety or depression. And it's regardless of race, it's regardless of socioeconomic status. It is more likely among those with no significant other. So it's not just necessarily people who are single, but people who do not have a person, who do not have somebody that supports them. And remember, we talked about that state of feeling abandoned and disconnected. You can see how that's linked. As human beings, we have a need to have somebody that emotionally looks after us and cares for us. But there's also a very strong hereditary component. And we know that these neurophysiological emotions are genetically determined to help us survive in theory, and therefore they've got strong neuropeptides that are involved in those neurological areas. And so therefore, if there are things in those neuropeptides that are unfortunately not working properly, you can get endogenous depressions and anxiety disorders. So just a major depressive episode, so this is not yet a disorder, is for at least 2 weeks, you get stuck in that particular emotional tunnel of feeling low, cannot enjoy life, problems with eating and sleeping, guilt, low energy. You all know those, and we're going to go through them in detail when we talk about death. So just to understand that a depressive episode is not yet a codable diagnosis, but you can use it in the description of what you are seeing when you are evaluating your patient. Great. So let's start with depressive mood disorders. Some I'm going to go through in detail and some I'm just going to mention. So we're going to talk about major depressive disorders, which can be single or recurrent. And we're going to talk about persistent depressive disorder or dysthymia. So they've taken out the term, they've combined dysthymia and chronic depression into this term now in the DSM-5. And then we're not going to talk about premenstrual dysphoric disorder. So this is more than just PMS. It includes actually having depressive symptoms a few days before the menses. Substance medication-induced depressive disorder can be either during or withdrawal of drugs, depressive disorder due to another medical condition, and then you get unspecified ones for depressions that don't quite meet the criteria or are much shorter than the definitions. So important, you'll see we do that throughout, to code a disorder for something that just becomes an emotion or a bad day and actually become a disorder. It has to have a certain duration, and it has to be causing distress and or disability. So either the patient is very upset about what is happening and it's causing them extraordinary distress over a long period of time, or it's making it difficult for them to either work or go to school or interfering with their personal relationships. And you'll see those two come up with all of our disorder diagnoses. Very important when we do look at all of our depression disorders is to always do our suicide risk assessments. And anybody with depressive moods needs to have risk assessments done. And it's never just a once-off. It's something you always have to continually think of. And important when you're doing your risk assessments is to just be aware which factors are actually static. It's not going to change. It's going to be ongoingly there. And which might be dynamic factors that's going to come and go. Suicide risk is careful. So watch out to write something like low, middle, or high risk, because it's actually extremely difficult to definitely say somebody's a low risk of suicide. It's easier to identify high risk of suicide. It's extremely difficult to identify low risk of suicide. So it's rather better to write out what is happening than simply put unless you can justify it very well. So the question is always in terms of which tools do we use. There's two major sort of evidence-based tools. There's the BECS, and then there's the CSSRS. I'm going to show you a little bit of those. So the sad person score, which I'll talk about, is particularly, we use quite a lot. That's the one we all know for suicide risk. And it's very good for determining if somebody needs to be admitted for suicide. But as a tool, it's got very poor evidence to actually classify the risk that the patient is in. So you just need to know which tool you use. The one that KZN Department of Health use, and is the only one that we sort of have available, is an adaptation of the Beck Suicidal Intent Scale. But you'll see the problem with these tools as well is what you actually do is you look at an actual suicide attempt or something that usually patients have come in and who's had a attempt, for example, in A&E, and then by evaluating that attempt, you can actually get to a whole scoring system and to be able to identify whether that patient needs to be admitted. So I'll send those scores around. So that's the BECS one. The CSSRS tool is long and complicated, and is not a tool that is based on scoring, but it's a tool that you fill in, and then you yourself out of that makes an assessment on what you think the patient's risk is. But they do have this, which is quite helpful in terms of giving out to family, for example, or having as a community or as a primary healthcare tool in terms of a screening tool initially in terms of risks for suicide. And that's also useful if somebody just has suicide ideation. So this is the modified sad person scale that we're using mostly in South Africa. It's quite easy to remember. And as long as you know, this is going to be really helpful to identify who you want to admit. You want to not use that to completely exclude risk. You're going to have to use your own sensibility to make a decision in terms of the follow-up and support that patient is going to need. So when we screen for depression, we need to have a very high degree of suspicion. So patients don't often come in saying they've got a low mood. They might also be masking. Just because somebody is smiling doesn't mean they're not depressed. And the most common symptoms in our setting, this is from the EML, is either insomnia or loss of energy. In African culture, quite often it might be bodily aches and pains, so somatic symptoms, or rumination, thinking too much, that may predominate. This is an actual line out of the EML update on mental health recently. Sometimes you might see psychotic symptoms, and sometimes it's difficult to figure out, to separate, is this somebody with a psychotic disorder who also happens to be quite low, or is it somebody with a mood disorder that's gone psychotic? It's kind of useful to look on whether the paranoia or the psychotic symptoms is congruent with their depression. So I feel depressed and I therefore believe nobody loves me and nobody cares about me. So major depressive disorder is about 7% of the population. So this is actually the disorder. Begins about the mid to late 20s, but can, of course, occur at any time. We see it in children as well as elderly people, and it can be sudden or gradual. There's no real rules. It's important to realize that even if we didn't treat it, if you just left a depressive episode, it seems to last about an average of 6 to 9 months. So it has sort of a life cycle, and most people do not stay depressed forever. Some people don't necessarily have the feeling of depression. They don't have this feeling of being overwhelmed, but they simply experience it as a loss of pleasure or a reduced interest in their usual activities. So they can't enter any of those positive rooms. They can't really feel it. They don't really feel like they care about people like they used to. They can't play games and do hobbies like they used to. They've lost interest in their work and their research, for example. So it's important to have those, to just differentiate those when we ask. And very important is major depressive disorder always has to have some sort of effect on functioning. And it doesn't mean necessarily that they're not at work, because we have to work. So people sometimes will work even if they're struggling, but they are struggling. They're struggling to maintain their normal functioning, and that's part of your diagnosis. So your major diagnostic criteria for depression is that mood. So remember, we talked about the quality of the depressed mood. They have to either have a depressed mood or that loss of interest. And then in the DSM-5, they've got 5 of those classic symptoms that we know with depression. The changes in appetite or weight, the problems with sleep, fatigue, either psychomotor retardation or agitation, the guilt, problems with concentration, and suicidal ideation. So these all need to be there pretty much most days for the last 2 weeks. And then very important, it has that distress and disability clause. So it must be something that's really affecting your ability to do anything. Important that it mustn't have been caused by another condition. The symptoms, so for example, if they've got insomnia due to hallucinations, that's not necessarily a symptom for MDD. And if they feel guilty because they're depressed, that doesn't count. The guilt must be an inordinate guilt about other things to be part of the depression. The depression causes the guilt about a whole range of other things. And of course, typically in DSM-5, you would say there's no other exclusion things like that, like a medical condition that can cause it. So in the EML, in the DSM-5, they talk about severity in terms of mild, moderate, and severe, which is basically to do with how much it influences. It's not a very useful classification in terms of mild is just very simply, they can still function. Moderate is somewhere in between, and severe is they can't really function very well anymore. So what we use in our setting as our most useful tool in terms of making a diagnosis is our PHQ screening tool, which is a useful way to help screen for depression, a very useful way to also help follow up on how a patient is doing on treatment, and also can give you some classification. Do you remember the name of the disorder is your major depressive disorder, your MDT, and then you classify your MDD as being mild, moderate, or severe. So you've all seen the PHQ, I hope. And the clever thing with the PHQ is you can use the first 2 questions of the PHQ, which is that little interest or pleasure, or the feeling down or depressed. And you can ask about the last 2 weeks, and you can score that. And if they've got 2 or more, then you will do the full PHQ-9 to give you an actual classification on how your patient is doing. So it's got a very high sensitivity and specificity for depression, which is quite useful. And it's also very helpful in terms of helping you follow up the patient once you start them on treatment. So when somebody has got a DSM-5, there's also what they call specifiers. So you can specify whether it's got atypical features. So if somebody's eating more rather than less, if somebody's feeling very sluggish or paralyzed, gaining weight, sleeping excessively. This is a very particular phenotype of depression, quite often young teenagers, youth, very sensitive to rejection. And this particularly atypical ones do not respond as well to our regular antidepressants. Melancholic features is just the classic picture we normally think of when we think of depression, but usually these the very severe ones. It's almost bordering on psychosis, and they literally got that psychomotor retardation. They're losing weight. They've got loss of appetite. They're not sleeping. So that very severe picture of depression. And then if they've got anxiety with it, and again, sometimes difficult to tell whether this is anxiety with depression or depression with anxiety. And sometimes they might have psychotic features with it. So just in terms of recurrent major depressive disorder, because quite often what we have is we have somebody's written MDD somewhere in the past, and now everybody just re-prescribes the prep. But we actually have to become clear, is this the first episode? When do we stop treatment? Is this a recurrent episode? So 50% of patients will have a second episode, and we need to warn them. That's quite normal. And we call it separate episodes. There must be at least 2 months where they were completely well in between 2 of those episodes. But usually people who have recurrent episodes, the average is 1 every 4 years. And then, of course, there's an extraordinary amount of variety. So it's not usually something that there are rapid cycling ones that happens regularly, but they're quite uncommon, and that's usually falls under psychiatry. Usually patients will have exactly the same type of symptoms every time. So there's a lot of variety in depression symptoms, but for that patient, it will always present in roughly the same way. And if people have multiple episodes, that's got a much increased likelihood of suicide attempts. And there's about a 4% rate of successful suicides in patients with MDD. Also realize that some of them might actually have bipolar. And so 25% of those may eventually, if they've got recurrent depression, might actually end up having a manic or a hypomanic episode. And then, of course, you'll change that diagnosis to bipolar. So let's just talk about persistent depressive disorder or dysthymia. We would usually just call it dysthymia. And that's, as I say, is a slightly newer way of how we're talking about chronic depression. So in a lifetime, they think that about 6% of adults may have dysthymia. So people who are chronically feeling very low. It's more common in women than men. And it usually starts quite early in life. It's got quite a high genetic component. And so some patients might actually think that this is the normal mood. This is just the way life feels. So they suffer quietly. The disability can be quite subtle. It doesn't affect you. It doesn't have quite as many of the symptoms as we see in the major depressions. And so some of them might never get treatment unless it goes into a major depressive episode. And classically, when you classify them, you would classify those that are early onset, those that started before 20 years, or those that start after 20 years of age. So the criteria is a chronic enduring depression that's usually for more than 2 years, where symptoms were never absent for more than 2 months. And it's relatively mild. So if it meets the full criteria for major depression, is actually not this chronic one. Then it's called unspecified, and the psychiatrist needs to look after them. I don't think people can function that severely depressed for such a long period of time. But they will have a low mood, they'll have some fatigue, they'll have no inappropriate guilt feelings, and they do not have any suicidal ideas. So that's very different from your major depressions, and that's why they're much more difficult to notice. So how do we manage these patients? So obviously you're going to assess your severity, do a suicide risk. Make sure there's no other underlying or comorbid conditions. So do your blood screens for other things that might be contributing, like your thyroid, anemias, and things like that. And obviously you want to see if substance abuse is in. So remember I said one of the ways we deal with negative emotions is using substances, for example. So quite often the two might go together. So in our setting, you need to try and figure out what kind of additional help is going to help this patient. Do they need stress management, coping skills? Is there life stuff going on? Then a social worker or an OT might be able to help. Is there relationship stuff as well? Then the social workers might help. If there's abuse or intimate partner or other violence, then please, we do have social NGOs and social worker spaces that can perhaps organize safe spaces. We do have psychologists here. So again, you'll need to see if you think this patient will benefit from actually having some psychotherapy as well. In the, they have updated the EML section on depression, and they have a whole section on psychoeducation. And I think a big problem is that both families and patients, especially our patients, do not understand what emotion is. So being able to describe those emotional tunnels that people can get stuck in can be very helpful. And you really want to be able to, and that your social workers can help with that, to enable them on how we're going to manage these months. It will help, the medication will help, but it will take time. You're going to need help and support to cope you while you're stuck in this tunnel for this time. And very much to address all these myths and misconceptions that we have around depression, that it's something that that's a weakness or somebody's just not coping, and really to talk about these underlying causes. So this is now straight from the EML. So we only have 2 options. You have 3 options. You have fluoxetine or citalopram, your 2 SSRIs. So We start slowly, mainly from a side effect profile, and to a little bit prevent the agitation you can see with fluoxetine. So you start with 20 milligrams alternate days, because we don't have the 10 milligram tablet, for about 2 to 4 weeks, and then you're going to go to 20 milligrams a day. So you can't even prescribe it for somebody and saying, have 20 milligrams every 2 days for 2 weeks, and then you're going to have 20 milligrams a day for 2 weeks, and then I'll see you in 4 weeks' time. If you see when you want to go up with the dosing that they're getting very agitated and suicidal ideation gets worse, then you're going to go a bit slower with your increase. And then you usually reassess after 4 to 6 weeks. And if they still not responded at 4 to 6 weeks, do your PHQ, then you can go up to 40 milligrams a day. And if possible, try and get your psychologist involved. The other option, if they don't manage the fluoxetine, or they're not tolerating the fluoxetine, is your citalopram. So that's 10 milligrams daily for the first week. Then you go up to 20 milligrams a day, again, reassess after 4 to 6 weeks, and you can also go up to a maximum of 40 milligrams a day. So both fluoxetine and citalopram, fluoxetine a bit more, can cause this agitation in the first 2 weeks as the neuropeptides find their way, and therefore people can get a bit more agitated, insomnia can get worse, and they can have increased suicide risk. It's very important to have this conversation with the family and the patient as a side effect of the medicine, because that makes it easier to manage as well. So the other option is tricyclic antidepressants, and this particularly if you need a sedating antidepressant. So somebody's quite agitated, and especially if they're not sleeping well at night, you would start with a 25 milligram knock-day dose. And look, you can put that dose up quite quickly, every 3 to 5 days. And remember, for antidepressant purposes, you need 150 milligrams per day, depending on what the patient can tolerate. So this is much more than what we use for the peripheral neuropathies. The problem, of course, with these is they're very fatal and overdose, which the SSRIs are not. And remember, not just for the patient, but now they're lying around in the house as well. And you want to avoid it in patients that are elderly or have heart disease, urinary retention, glaucoma, or epilepsy. And not to use in patients with bipolar. And just to also be aware, amitriptyline, there's various other things that might interfere with it. So how long do we give it? We want to give the treatment for 9 months, and you're only going to stop if there's no or minimal symptoms and the function's back to normal. And there are some patients where you might give it for example, a year, if they've got anxiety as well. If they've got previous episodes of depression, you might give it for 3 years, or very severe depression, you might also use 3 years. And if they've had 3 or more episodes of depression, then you might advise lifelong treatment. And our outcomes, we talk about partial remission and full remission. So your full remission is basically they must have had no symptoms for at least 2 months, and you can use your PHQ to do that. So that means that we want to get into a habit when we see patients who've been on their antidepressants for 9 months and they're scoring fine on their PHQ, to say to them, let's see if we can start weaning you off. But there is a discontinuation syndrome due to with your SSRIs. And so you have to slowly taper that drug over at least 4 weeks. And it's not that the depression necessarily comes back, but they get like flu-like symptoms and dizziness and vivid dreaming and a bit of irritability and some funny concentration things. So it's funny side effects you have to explain to the patient. And you can go really, really slowly when you reduce that antidepressants. And if they start getting the symptoms as you're going down, then you just reintroduce at the previous dose and then taper even slower. But actually, fluoxetine causes less discontinuation symptoms than citalopram. Just in terms of pregnancy and breastfeeding, so 50% of women do get the baby blues, so that's quite normal, but 10% of women might develop MDD, which can be a disaster in terms of both for mom and baby. So all of the antidepressants can have, it's low risk, but there are some possible risks to the baby and the newborn. But it's generally a risk-benefit sort of calculation. If you're starting somebody newly, citalopram is a little bit better than fluoxetine in terms of safety for the baby. But if somebody's on fluoxetine and managed really well on fluoxetine, you can keep them on the fluoxetine if they fall pregnant. Just don't use any benzos in pregnancy. Great, so let's just talk about anxiety disorders. And remember, anxiety is a normal symptom to perceived anticipatory stress, like we talked about earlier. So we're supposed to go into those rooms when we're feeling fearful, into those tunnels, And your challenge is often it can present with all these physical symptoms because it's your fight-flight system that's kicking in. So you might have non-cardiac chest pain, there might be abdominal discomfort, there might be neck tension. And it can also be brought on by various medical conditions, and it can exacerbate medical conditions. So it can sometimes be really complicated when you've got a patient in A&E to figure out, are they having a panic attack, or are they having a heart attack, or they're having both. So it's sometimes because the anxiety is a natural part. It can also quite often coupled with substance abuse problems. So it might be the substance abuse that's actually causing the withdrawal, that's causing the anxiety. And it can be a completely different mental disorder, like obsessive compulsive disorder also presents with anxiety. So as we mentioned, there's different ways in how you deal with anxiety, and using substances is a common way that people try and manage their anxiety. So often it goes together. So also if you've got somebody who's coming in with substance abuse problems, you need to actually screen them to see whether there might be anxiety underlying. And some people with intellectual disability or with neurodivergence, for example, might actually not present with anxiety, but it might come out as aggressions or agitations or demanding behavior. Remember our different dragon behaviors. So again, I'm just going to talk about panic disorder, generalized anxiety disorder, and I'll mention very quickly agoraphobia, social anxiety, and specific phobias. I'm not going to talk about separation anxiety disorder, that's more in children. Substance medication-induced anxiety disorder, that sort of tells you what it is. And then there's, of course, the ones that's due to medical conditions or unspecified. I'm not going to talk about the major psychiatric ones. Usually those are much more complex, like obsessive compulsive, PTSD, and personality disorders. And you want to involve a psychiatrist and psychology care for patients with more complicated disorders like that. So great. Again, for our screening, we've got the GAD-7, which is sort of the anxiety version of the PHQ-9. And again, you can use those first two questions, which is about feeling nervous, anxious, or on edge, on not being able to control or stop worrying over the last 2 weeks. Again, you do a scoring, and here is a score of 3 and more that will need, then you need to do the full GAD-7. And actually, it can be useful for all of the anxiety disorders to be able to get an idea, and it helps you to score a little bit what their level of anxiety is. So panic attack itself is not actually codable. It's a bit like a mood episode. And everybody has panic. 30% of people will have at least one panic attack in their lifetime because it is part of that anxiety cycle of us. And it's got a broad spectrum of frequency, obviously, in different people. And you get panic attacks that are cued. So a particular thing that scares you happens, and then you get a panic attack. Or it might be uncued. So you start having a feel of anxiety. You get scared that you're going to have a panic attack. That makes more adrenaline, and you get a panic attack because of the underlying anxiety, and there's nothing that's actually triggered that. So it can be very debilitating if you're scared about having another panic attack. And if somebody's having a panic attack, sometimes it's just reassuring them, paper bag, helping to calm that adrenaline down. It can be quite easy to manage, and it becomes more complicated when people get stuck into a disorder. So, of course, the problem is that if you've got mood disorders, and a lot of your other disorders can also have panic attacks, so it's also a qualifier. So what do we call a panic attack? So it's defined as a fear or a stark terror that begins suddenly. It begins abruptly and builds to a peak. It lasts less than 30 minutes, and you have to have somatic symptoms with it. So remember, panic attack is a bodily thing, and it's very helpful to explain that to patients. Although it's this emotional tunnel that you get stuck in, the thing that keeps you there is all these emotional symptoms, whether it's the chest pain or the fast heartbeat or the fast breathing, the tingling or the numbness, the tremor, the fear of losing control. So all of those are very much bodily symptoms. So what we call a panic disorder is a very common anxiety disorder. It starts during the early 20s. It's quite a high percentage of our general population, more often in women. And a panic disorder, the definition of that is that you must have had at least one panic attack, which was then followed by a month of fearing attacks, so much so that it affects your behavior in your life. So you get so frightened of having a panic attack that you start avoiding all kinds of situations where you think it might trigger that panic attack. So it causes distress or disability. And of course, you want to exclude any other disorders or other specific things that might be triggering that panic attack. So we can use panic attacks as a qualifier for other conditions, and that's separate from somebody who has a panic disorder. So generalized anxiety disorders, so this is the one that we need to get better at diagnosing. And it begins at around about 30 years of age. About 9% of the general adult population is a lifetime risk, and it also has an important genetic factors. So we find some people are also, especially neurodivergent people, will have more tendency to get generalized anxiety disorder, or if you're somebody that's highly sensitive and you take in a lot more sensory information than, for example, neurotypical people, you are more likely to get overwhelmed and more likely to get triggered into these anxiety states. So it's defined as hard to control excessive worrying about a variety of issues, and the worry is usually in excess of the actual problems that's going on. And it's accompanied by physical and mental complaints. So muscle tension, restlessness, becoming easily tired, struggling to concentrate, trouble with insomnia. And you can see it must have been at least 6 months or more for most days, and it must have distress and disability. So it's actually affecting your functioning. And of course, you have to exclude all your other anxiety disorders. So the next three I'm just going to mention very quickly. So agoraphobia is where somebody's worried that if they end up being in a scenario where they escape's going to feel difficult, or something embarrassing is going to happen and they're going to be trapped in a particular scenario. So it's an inordinate anxiety to go into spaces where they're going to feel they're not going to be able to control what's happening. So that could be riding a bus, going to a shopping center, going to a theater, being part of a crowd. And you also want to exclude other anxiety disorders. And people like that can quite often get quite severely housebound if it gets very severe. Social anxiety disorder is also quite common. Starts medically tip middle teens, and that's any scenario where you're worried about getting embarrassed. So this includes performance speaking, for example, or anywhere in a scenario where where other people are around and you worry that you're going to look clumsy or silly or shameful. And then you start avoiding scenarios because of that fear. So again, it must be something that's happening on most days for more than 6 months. And again, it must affect your life negatively. So because sometimes one wonders, well, how do you now tell whether it's panic disorder or agoraphobia or social anxiety disorder? Because all three can give panic attacks. And this big thing is to figure out, is there a cue? So if there's not a cue and the panic just comes out of nowhere, that's more likely your panic disorders. So look at all the situations. If it's very specific situations that always triggers those panic attacks, then you can start figuring out whether it's agoraphobia or social anxiety. If people awaken at night with panic attacks, that's more likely to be panic disorder. And you're trying to figure out what is it that causes this fear. And are they worried about having the panic attack? And that's more likely your panic disorders. Specific phobias, you all know about this, things people get scared of. So phobia itself is quite common, but it only becomes a disorder again if it's there every day for most days, and it's starting to impact on your life. So if you're terrified of spiders, but it's not impacting on your life, then that's not a phobia, social phobia disorder. It's just a social phobia as an uncodable phenomenon. And there's lots of different ones that can also then trigger panic attacks. So great. So how do we manage that? So very important is that we need to screen for it. So make sure there's no medical things that might be contributing to that anxiety. So look for your thyroid stuff, look for your parathyroid, remember your pheochromosomatomas, especially people who are suddenly coming with massive anxiety symptoms. Your cardiac conditions, things like COPD and asthma can cause anxiety, and very important to check and manage what's happening with substance misuse in those patients. Anxiety, of course, can be very strongly triggered by what's happening also with psychosocial stresses, so what's happening in your life. So just our patients with disability or challenges, what's going on in their lives, recent bereavement, all kinds of things can also trigger anxiety. And it's very important to explain to patients what anxiety is. And a lot of patients do not understand how anxiety works. The SADC website has got quite nice, quite nice leaflets and local support groups as well that one can go in. So it's always helpful for me to really sit down with a patient and explains to them how adrenaline affects the symptoms. So describing to them the cycle, the adrenaline cycle. A threat triggers the survival brain, which makes adrenaline, that makes your body go into the fight-flight symptom. It causes all those symptoms. That's going to make you worry and think about all the negative things I need to do to prevent this threat, which makes more adrenaline, and you get stuck in this stress cycle. There's two major ways in which we try and teach patients how to interrupt that cycle, and usually our social workers and counselors help us with that, but you can also give patients basic advice on how to do that. So the one is being able to actively relax the body. So if you actually take the tension out of the shoulders, take the tension out of the muscles, your body gets a message that the threat is past. So those typical relaxation exercises we always talk about. And then working with things like mindfulness, if people do prayer, meditation, there's a lot of different cognitive behavioral therapy work, particularly on how you quiet those irrational thoughts that might be coming. So medical treatments are very important. Most of it is actually helping people become aware of what it is and trying to get out of that feedback loop. So very important, either yourself or somebody actually needs to teach people how to respond. If you are going to use medication, you need to monitor them regularly. And our medication is, again, just the SSRIs, which is not as effective in anxiety disorders as they are with depression. And it's exactly the same dosing as we would use for depression. And of course, we also have to now watch out for that agitation. And again, if the fluoxetine might make the agitation more worse, citalopram is your other option. I guess it's the same dosing as with our depressed patients. But you've got to watch out, especially in these patients, for that early agitation. And both the family and the patient needs to be aware, and there needs to be somebody that keeps an eye on them during that time. Just a caution so continue your treatment for a minimum of 12 months with anxiety disorders. So that's longer than with your depression. And again, you're going to slowly taper if you need to taper, and you will only do that once that patient feels they're able to manage their routine life as well. And then again, if there's severe episodes of anxiety or very young onset or suicidal attempts, actually, you might actually continue that treatment for 3 years. And again, 3 or more previous episodes, you might even advise lifelong treatment. Just a word about benzos. So benzos is not the treatment for an anxiety disorder. Benzo is something that you can use for somebody who's got short-term severe anxiety or distress. So for example, after a severe trauma, if you've got somebody who's, for example, gone through sexual assault, somebody's gone through a severe bereavement of a child, for example, and is not managing, we can use benzos. And benzos is basically like, I would say, it's like certified alcohol. You're basically prescribing a substance that temporarily calms that system down. It's like wrapping them in cotton wool. But of course, it's not a long-term option. And you do not want people to start using that benzos as the way they're going to manage their anxiety, because this is not a long-term option. So if you do use it, you can use diazepam. In our setting, this is in the EML, 2.5 to 5 milligrams as a single dose. Repeat 8 hourly with a maximum of 30 milligrams. Of course, they get tolerance quite quickly, but again, you're going to use this for very short periods of time. In the EML, they recommend no longer than 2 weeks, and then you taper off to 0 within 6 weeks, and you've got to keep a very close eye on that, because patients can start shopping around with different clinicians if you're not careful. The benzos is also just a short thing that you use while you're starting your other treatment. And just to watch out, remember, it does cause cognitive impairment. It's literally like you're putting them under the influence. So they should not be driving or using heavy operate machinery or things like that. And very careful in our elderly. So great. So in summary, make a diagnosis. So use our tools, use our PHQs and GADs, screen, make diagnoses. We're very much diagnosing depression and anxiety. We have to get really good in explaining to patients what's going on. The depression and anxiety diagnosis are very poorly understood. And so using some of those neurophysiology I've spoken to easily, talking about these emotional rooms and tunnels can be very helpful. And then very much so, quite often you'll have the same scenario in the district hospitals and the CHCs. You're going to pick up patients who were started on antidepressants once upon a time. So try and figure out, is this the first episode? Is this recurrent? How many months have they been on treatment? At which stage do we actually need to start phasing? Otherwise, you have people who are actually been started on treatment, but are not actually monitored for their mood disorder at all. Thank you very much. And yeah, we can open it up for some questions.